explain this way. So you'll of course try to establish that that the patient's weakness is lower motor neuron in nature. Then after which we will decide whether the patient is predominantly distal, like in this case, or predominantly proximal, like in this case. Then the next question in our system of examination would be from history as well as examination. We will try to decide whether the sensation is normal or abnormal. Okay. So if the sensation is abnormal and if it is confined to one or two limbs, then we know it doesn't fit into a nice glove and stocking pattern. If it doesn't fit into a nice glove and stocking pattern, then we realize there are two possibilities. We're dealing with peripheral nerve, individual peripheral nerve disorders, or we are dealing with individual segments, nerve root disorders. Most of these times, the patients have isolated peripheral nerve or isolated nerve root involvement. For example, this patient with a peroneal neuropathy, this patient with a C8 radiculopathy, this patient with a radial neuropathy, it can be isolated, just one nerve. But whenever you see that a patient's pattern of weakness and sensory loss seems to be more than that of nerves, are we dealing with brachial plexopathy or lumbosacral plexopathy? Now, of course, a patient with focal weakness can also present with proximal weakness. If it's proximal weakness with normal sensation, again, we have to start thinking, especially if it's more than one distribution, are we dealing with a lumbosacral plexus if it's the lower limb, or brachial plexopathy if it's the upper limb? Okay, so this is the general scheme that I'll be using time and again. But the first message that I would like to transmit as far as brachial plexus or any plexopathy is concerned is that we have to overcome the fear that we have of the complexity of the brachial plexus. And I must give credit to this good work by Dr. Ferrande and the late Dr. Wilborn, who've written a beautiful seminal article from which I learned a lot. And most of what I'm going to discuss is actually derived from the methods propagated in this seminal paper. Okay, so how do we overcome the fear of the brachial plexus? Now, I would start off by very simply saying that you only need to remember only one thing. And the only one thing you need to remember is that the brachial plexus is made up of 5, 6, 7, 8, and T1. Because there's no way you could possibly figure this out. You have to memorize this. But beyond that, I would like to propose that we don't have to memorize anything more than that. Let me show you why. Because if you think about it, if C5, C6, C7, C8, T1, we have 5. And we need to form 3 trunks. So obviously, we take the first 2 and form the upper trunk. We take the bottom 2 and form the lower trunk. Okay? And then, of course, you have no choice now, but the middle trunk must come from C7. So without much memory, you know that C5, C6 make the upper trunk, C8, T1 makes the lower trunk, and C7 makes the middle trunk. Then we know that the arm is actually an extension of the body, right? As we know, we all started off with a tubular sort of structure and then the arms grew out of it. While the arms grew out of it, they pull the nerves through into the arms. If they pull the nerves through the arms, the anterior compartment, which is predominantly for flexion, and then there's a posterior compartment is predominantly for extension. So that means the nerves, as they're entering the brachial plexus, must divide into anterior and posterior division. And obviously, the posterior division must go to the extensor compartment. And that will remind you that all 3 posterior divisions must merge together to form the posterior cord. And what is the predominant nerve in the posterior compartment? Extensor nerve, radial nerve. So it must be the radial nerve. So all 3 posterior divisions merge together to form the posterior cord. The posterior cord goes on to form the radial nerve. And just before it becomes the radial nerve, the axillary nerve will come out of it. Okay, so we have covered a significant part of the brachial plexus already. Now, if you look at the arm, now remember the nerves were coming out through the arm from the body. Now, the lowest part must be coming from the lower part of the brachial plexus. So, the lower trunk. The lower trunk has got an anterior division. If the anterior division follows through all the way to the end, what will it meet? You will meet things that are innervated by the ulnar nerve. So that will remind you that the anterior division forms the medial cord and it goes on to form the ulnar nerve. Okay, so the anterior division of the lower trunk goes on to form the medial cord because that's the medial part, and naturally, as you can see, it goes on to form the only structures here are the ulnar innervated structures. So therefore, it must be the ulnar nerve. And because it's going through the medial part of the forearm, that will remind you that it must give off the medial cutaneous nerve of the forearm before it reaches the ulnar nerve, before it becomes the ulnar nerve. So now we have the radial nerve, we have the ulnar nerve. Now, what do we have left now? We took the posterior divisions of all the trunks. We took the anterior division of the lower trunk. What do we have left? Therefore, there was no choice. We only have two left. We have the anterior division of the middle trunk and the anterior division of the upper trunk. So what must we do? We have no choice but to merge them to form the lateral cord. And the lateral cord goes forward, and the first muscle that will meet is the biceps, and it will go on. And remember, there was a medial cutaneous nerve of the forearm, and therefore there must be a lateral cutaneous nerve of the forearm. So therefore, you're not surprised that it's called the musculocutaneous nerve because it is an extension of the lateral cord. So now we realize that we have actually, just by working through, just by memorizing just only one thing, C5, C6, C7, C8, T1 makes up the brachial plexus, we have figured out almost all the nerves. Now the only nerve that's missing is the median nerve. Now median nerve is very interesting. And the way to remember it is looking at our brachial, our patients who come to us with carpal tunnel syndrome. So this is a classic carpal tunnel patient, right? What does she complain of? She complains of weakness in the thenar eminence, which is mainly T1, lower part of the brachial plexus. But she also complains of numbness here, here, and here. So what areas are these? These are C6 and C7 areas. So you realize that the median nerve has to be very complex. It has to come from two very disparate parts of the brachial plexus. So I think whenever I talk to my Egyptian friends, you have heard me make this joke about how in history we had a northern Egypt and we had a southern Egypt, and then the northern and southern Egypt merged together to form the greater Egypt, right? So the same way, the median nerve must be a combination of two branches coming from the upper part of the brachial plexus and the lower part of the brachial plexus. And the only way you can do that is to get a branch from the lateral cord and a branch from the medial cord. The branch from the medial cord obviously is responsible for the thenar eminence, and the branch from the lateral cord, which is coming from this area, will be responsible. Remembering our carpal tunnel patients, we'll be able to figure out that the median nerve comes from branches coming from the lateral and the medial cord. Okay? Now that we have got all the big nerves out of the way, we only have a few small nerves to worry about. We have the suprascapular nerve here. The suprascapular nerve coming from the upper trunk, C5, C6. We have the long thoracic nerve.
Sorry, Prof. Anyone?
Because this requires a little bit of memory. This requires a little bit of memory, but beyond that, I think we could work out most of the thing. Okay, so now realize that we've got the whole. I think somebody's Zoom is not on mute, so it's very loud.
Clear, please.
Okay, I'll try to speak over the noise. It's okay. Okay, so now we have gotten the brachial plexus anatomy sorted out. But let's think about the functional anatomy. The functional anatomy for clinicians has to think about the nerves from a different angle. So for example, whenever we think about ulnar nerve as a clinician or as an electrodiagnostician, we have to think that this is the ulnar nerve. Where is it born? It's born at CAT1. How does it get, what primary school does it go to? It goes to the lower trunk. Then after that, what secondary school does it go to? Anterior division, medial cord, and then it ends up in the final location. So by knowing all these structures, okay, we have a detailed anatomy, not just of the ulnar nerve, but also how it traverses through the brachial plexus. Likewise, the radial nerve is born at C7 and C8. Okay, it has to travel through it has to travel through it has to travel through the middle and the lower trunk. Okay, then posterior division, posterior cord, And then finally the muscles of the radial nerve. Median nerve we already discussed, right? There are two components to it. The lower part comes from CAT1 through the medial cord. The branch comes out from the median nerve. The upper part comes from C6, C7 through the lateral cord and forms the median nerve. So likewise, if you look at the axillary nerve, this is an important one. So I want you to pay attention to this. Axillary nerve is born in C5, C6. Where does it go to primary school? It goes to upper trunk. But then after that, it leaves up that primary school and goes to secondary school and I use the analogy of primary and secondary school to just explain how they reach the final location. So C5, C6, upper trunk, posterior division, posterior cord, and then to the deltoid muscle. Okay. Now, a very similar nerve is the musculocutaneous nerve. It also starts from C5, C6. It also goes to upper trunk, but it goes to a different secondary school. It goes to the anterior division and lateral cord, and then to the biceps muscle. So this is very useful for the clinician, right? Because remember, we always talk about the zebra stripe, right? If you want to differentiate a zebra from a horse, we shouldn't talk about the forelegs. We should talk about the black and white stripes. So if you want to know whether the patient's problem is in the posterior cord or lateral cord, then looking at axillary nerve and musculocutaneous nerve clinically, as well as by EMG, would be ideal. Because axillary nerve and musculocutaneous nerves share the same nerve roots, come from the same trunk, but they go through different cords. If you want to differentiate a posterior cord from a lateral cord lesion, what muscle must you look for?
طب انت اللي حكيت ان انت جايبه انت ليه طيب
traveling through both the upper trunk and the middle trunk. But then, unlike the musculocutaneous or axillary nerve, it goes up to the, unlike the axillary nerve, it goes up to the lateral cord and ends up in the median nerve. So, if you want to differentiate, again, a middle trunk problem, for example, okay, or a C7 problem from axillary nerve, then the muscle that you want to, from C5, C6 or upper trunk problem, then the muscle that you want to go for is the pronator teres. Let me explain this one more time, just because it's an important point. So axillary nerve comes from C5, C6, goes to the upper trunk, okay, then it goes to the posterior cord and ends up in the axillary nerve and the deltoid muscle. Pronator teres, the nerve to the pronator teres muscle, starts off from C6, C7, okay, goes through both upper and middle trunk, okay. Then instead of going through the posterior cord, it goes to the lateral cord. So again, if you want to differentiate a lateral cord lesion from a posterior cord lesion, just like looking at axillary nerve and musculocutaneous nerve, you can look at deltoid muscle versus the pronator teres muscle. Likewise, because the pronator teres has C6, C7 as opposed to C5, C6, you can again use the pronator teres muscle to differentiate a lesion in the C5, C6 region as opposed to C6, C7 nerve roots. So the reason why we're emphasizing all this anatomy is these fine details about the anatomy will allow you to interrogate the patient more exquisitely and detect lesions within the substructure of the brachial plexus. So likewise, when we study the sensory nerves, now many of us will study, for example, a routine nerve study that we do is digit 5, right? Digit 5 ulnar nerve. So digit 5 ulnar nerve comes from C8. It travels down the lower trunk, medial cord, and reaches the digit 5. Now, digit 2 that we often use for carpal tunnel is not so useful when we want to interrogate the brachial plexus, because 50% of the time it's coming from C6, 50% of the time is coming from C7, digit 2, okay? While we prefer digit 1, which is your thumb, because most of the time it's coming from C6, upper trunk, anterior division, lateral cord, and then median nerve. So when we are studying these nerves, we know which part of the brachial plexus we are interrogating. Now, some of you may be confused. Why am I talking about all these things? Because from a practical point of view, you can't possibly be thinking about all these things in the busy electrodiagnostic clinic. And that's when you are seeing a patient, a table like this is very useful. A table like this is actually derived from this, except that I've inverted it the other way around. Okay, this has been inverted. So all you need to do is that if you suspect a patient has upper trunk pathology, and the differential diagnosis is lateral cord, okay? Differential diagnosis is lateral cord. Then you can start doing these sensory nerves and see which are abnormal. If the nerves on this side of the box is abnormal, but this side of the box is normal, then you start thinking this must be upper trunk pathology. Likewise, these are the motor nerves you would interrogate when you are suspecting upper trunk pathology. And this is the motor nerves you will interrogate if you are suspecting lateral cord pathology. And likewise for EMG, these are the muscles you would EMG when you are suspecting upper trunk pathology. And these are the muscles you will be interrogating if you are suspecting lateral cord pathology. Okay? Now, of course, based on the zebra stripe principle, it becomes obvious that if the pathology is confined to these nerves, but these nerves are spared, then of course the problem would be in the upper trunk. Okay, and likewise, if the pathology is confined to these nerves, these structures, but not these structures, then obviously the pathology is confined to the lateral cord. Okay, so let's use some examples to illustrate that. This is a middle-aged man presenting with fairly sudden, severe, unremitting pain over the right shoulder. He requires it so bad that he needs to rush to the emergency department and he needs opioids for a few days. After about 1 week, the pain settles. Then he notices, as an afterthought, that his shoulder is actually very, very weak and there's severe wasting of the shoulder, even though the onset was only about a week. Examination suggests wasting of the deltoid, biceps, periscapular muscles, absent biceps and brachioradialis reflex, and mild sensory loss over the lateral aspect of the forearm. So again, if we go back to this diagram, clearly the signs are lower motor neuron. The pattern of weakness is predominantly proximal. Okay. Sensation is clearly abnormal. Okay. So we could be dealing with a plexus pathology. In this case, obviously, because of the structures that are involved, this could be upper trunk brachial plexopathy, or we could be dealing with biceps and brachioradialis, so must be C5, C6 radiculopathy. So using our favorite animal, how do we differentiate between C5, C6 radiculopathy from upper trunk brachial plexopathy? You will take a table like this, okay? You know, you are thinking about upper trunk.
Okay.
If this was indeed upper trunk brachial plexopathy, as you would think about in a patient with, this story sounds very much like Parsonage-Turner syndrome, you would expect that the sensory potentials of the lateral cutaneous nerve of the forearm, digit 1 median, will be abnormal. If this was from C5, C6, because it's a preganglionic lesion, you would expect the lateral cutaneous nerve of the forearm and digit 1 to be normal. So actually in a busy electrodiagnostic clinic, just starting off with the sensory potentials of these two will straight away, of course, we have spent a lot of time in history taking, we spent a lot of time in detailed clinical exam, and all we needed to do was think about what we needed to do and did those relevant nerves. Lateral cutaneous nerve of the forearm, digit 1, if they are abnormal, they must be plexopathy. If they are normal, they must be a preganglionic lesion in C5, C6 radiculopathy. Then you would investigate the patient accordingly. Of course, you could do the motor nerve studies and you could do the EMG. And in EMG particularly, you will go for cervical paraspinal because you would expect the paraspinal muscles to be more affected in C5, C6 radiculopathy, okay, as opposed to brachial plexopathy. Okay, so you realize that the time spent in actual electrodiagnosis can be very short because of a very careful clinical analysis and planning of the study. Let's go on to another patient. Okay, a 50-year-old lady comes to us with complaining of weakness and numbness in the right hand for the last 6 months. She has had right mastectomy 2 years ago for carcinoma of the breast. There was evidence of local spread, so she received radiation to the axilla. She also has a long history of neck pain, and the general practitioner who sent you, the patient, has done an X-ray of the neck, and the X-ray shows multiple bony spurs. So again, clinically, they are worried about 2 different pathologies. So let's have a look at her. Her examination is again lower motor neuron. Okay, the pattern of weakness, because it's mainly in the hand, is distal. Sensation is clearly abnormal. Okay, so we are either dealing with a nerve or a nerve root. Okay, but clearly the weakness is involving more than the distribution of one nerve, thenar and hypothenar eminence. So it cannot be one nerve. It must be more than one nerve. And we already said, whenever you see more than one nerve in one limb, you must start thinking about plexus, right? Likewise, if it is more than one segment, you have to think about multi-segmental disease, okay, which can happen, okay? So differential diagnosis is right lower trunk brachial plexopathy, okay, versus C8 and T1, because obviously C8 cannot explain just thenar eminence, so you need both. C8 T1 radiculopathy. Again, how would you differentiate it? We go to our table. In the lower trunk pathology, you would expect digit 5, very easy nerve to do, routine nerve conduction study, ulnar nerve recorded at digit 5 will be abnormal. And you add on one more nerve, medial cutaneous nerve of the forearm. If these 2 are abnormal, we know straight away this is a plexopathy. If these 2 nerves are completely normal, even though she had carcinoma of the breast, even though she had radiation to the axilla, we would be more suspicious of C8T1 radiculopathy because it's a preganglionic lesion. And therefore, we would go on and do EMG of the paraspinal muscles and confirm that the paraspinal muscles are affected. And of course, clinically, you would also expect with C8T1 radiculopathy, some evidence of Horner syndrome on the ipsilateral side. So this will be very important, right? Because a lot of these patients, they have coincidental degenerative spondylotic disease in the spine, shown on the X-rays. But they also have a very sinister sounding history, like carcinoma of the breast to radiation. 2 things could have happened. She could have had recurrence of the carcinoma with metastatic disease to the axilla involving the lower trunk, or that she's getting the delayed consequence of radiation plexitis, as evidenced by the as you would suspect from the very prominent fasciculations that were noted in her. So these are the 3 different diagnoses. As you can see, all 3 have serious connotations. So the electrodiagnostician is very important in discerning, firstly, that it's the brachial plexopathy and not the radiculopathy. And then also by EMGing these muscles, okay, EMGing these muscles, if he finds a lot of spontaneous axonal hyperexcitability syndrome, for example, myokymia, neuromyotonia, these are features to suggest that this is more likely to be radiation plexopathy rather than metastatic disease. So with this information, although it's not a foolproof information, you can still have metastatic disease on top of radiation plexitis. You could at least help the oncologist manage this patient and get them away from the distraction of the spurs that were noted on the cervical spine MRI, cervical spine X-rays. Okay, come to the last patient. This is a very interesting patient. She came to us with this story that she has chronic wasting of both hands, chronic wasting of the right hand, okay, with not much sensory complaints. So the the neurologist who referred this patient to me was actually suspecting motor neuron disease because she had insidious onset of this wasting with not much sensory complaints. And you know, many of us are familiar with this split hand sign. The split hand sign is a very interesting sign that, you know, motor neuron disease is a disease that affects anterior horn cell in segments. So if it's affecting C8, all the C8 anterior horn cells should die. If it's affecting T1, all the anterior horn cells should die. So if it's affecting CAT1 segment, it should affect both the hypothenar eminence as well as the thenar eminence as well as the hypothenar eminence. But in motor neuron disease, often you find that the thenar eminence is disproportionately wasted together with the first dorsal interosseous, but the hypothenar eminence is relatively spared. So if you think about it, it's like a split hand phenomenon. This part of the hand is not wasted. This part of the hand is wasted here as well as here. So this and actually it is quite a useful sign because we often see this sinister sign in motor neuron disease. So she seems to have it. As you can see in the next picture, you can see that the thenar eminence is very wasted here and together with the dorsal interosseous. So this part of the hand is very badly affected, but hypothenar eminence is very, very fleshy, quite normal, correct? So this made the referring physician was very worried about motor neuron disease. So actually the referring diagnosis was motor neuron disease. But what we did was we spoke to her at length, and then we went through the protocol, lower motor neuron distal weakness. And the key thing, as you can see here, as you can see in this diagram, is whether the sensation is normal or abnormal, right? You cannot make a mistake here. Because if it's normal, you get different diagnosis. Abnormal, you get different diagnosis. So we went through in detail, and if initially she was a little bit vague, but when we persevered, okay, and examined her more carefully, as you can, I don't know whether you can hear my video. So here I'm asking her, how much is this? She says this is $100, okay, but the right hand she says is $70. So she gives me a 30% decrease here. So likewise, when I do it here, this part of the medial part of the forearm, $100, but she will only give me $50 per 100. This is 100. How much is it? 70 or $70. Okay. So it's about 30% decrease. So there is some sensory loss. So that is a bit worrying, isn't it? So if there is sensory loss, then you think if there is sensory loss, you have to come to this part of the algorithm, right? If this part of the algorithm, then you have to start thinking about, because it's more than one nerve distribution, are we dealing again with a plexopathy? Okay. Or could it be a nerve root? Again, if it's nerve root, it has to be CAT1. But then she's not sure about the sensory complaint. And it's quite subtle. So if we are wrong about the sensory abnormalities, then we are dealing with two differential diagnoses here. Multifocal motor neuropathy or some form of motor neuron disease, which was what the referring physician sent us. It could be ALS or it could be one of those limited form of motor neuron disease. So these were the various differential diagnoses. So we decided to examine her a little bit more carefully. So the sensory exam, we dug and dug and dug, and she said that maybe if the sensory loss is present, if she carries a heavy objects and walks for long distance. And then when we looked at her a little bit more carefully, we noticed that there was some fullness in the right supraclavicular area. Now, you may be more convinced if you see the gold chain here. It's a bit lower than this gold chain. It's going across. You see, you can see here the shadow. It's going across the supraclavicular fossa. Here it's sitting nicely here. So there seems to be a fullness here. And in the next video, maybe you can appreciate it a little bit better. There is some fullness here. And maybe you can even see a little bit of pulsation. Okay. Then we were not quite sure about it, but we couldn't get it tested. This is just before COVID and all that. So, no, actually this was some time ago, but I'm not sure why we didn't get tested. So in the dark room, we noticed that the right eye was slightly myotic, slight ptosis, okay? And yeah, and there's what we call the reverse ptosis sign, right? So slight ptosis and slight meiosis in darkness. Okay, I'll play it again. It's very mild ptosis. So again, if this was clear-cut honest, then that would point towards a T1 radiculopathy, very proximal lesion. So it looks like the candidates for this race are all racing, and they all seem to be equally likely to win the race. It could be CAT1 radiculopathy, it could be lower trunk plexopathy, it could be motor neuron disease of some sort, or it could be MMN. So what do we do? Well, we go to our faithful table. Okay, how do we EDX her? Well, if you look at our, we are thinking about lower trunk. If it's lower trunk plexus problem, what do you expect to see? You will expect to see digit 5 abnormal. You would expect to see medial cutaneous nerve of the forearm abnormal. If it's MND, this should be normal. If it's MMN, this should be normal. If it's CAT1, this should be normal. So first test you would do is digit 5 sensory potential and medial cutaneous nerve of the forearm. If it's abnormal, you got the diagnosis, end of case, correct? Yeah. But of course, we cannot make such a short electro diagnosis. We will go on. And what do we do when we do the motor studies? So in the motor studies, you'll be particularly interested to see whether there is any conduction block. So here I would study the median ulnar nerve very carefully all the way to Erb's point to see whether there is any conduction block, because this is a very treatable disease. Although a wasting is disproportionate, usually you don't see this level of wasting, but nevertheless, because it's a treatable disease, we have to look hard for it. So we look hard for a conduction block and we didn't find it. Then of course EMG will be very useful because the cervical, remember she had a bit of, we thought she had Horner syndrome. So if she had Horner syndrome, there should be, it could be a radiculopathy, CAT1 radiculopathy. If it's CAT1 radiculopathy, there should be denervation in the paraspinal muscles. Okay, so this is how you would have addressed this patient's electrodiagnosis. So that's what we did. Okay, and the answers for the electrodiagnosis was, well, first of all, we did find a decreased snap of both digit 5 sensory potential as well as the medial cutaneous nerve of the forearm. But more interestingly, the medial cutaneous nerve of the forearm was completely gone while digit 5 was reduced. Clinically, the same thing also, right? Remember, she said there was mild numbness in the digit 5, but 70%, 30% reduction in the medial aspect of the forearm. So that means the medial cutaneous nerve of the forearm is affected more than digit 5. And likewise, when we did the median ulnar nerve study, we didn't find any conduction problem. But we found that the median CMAP, as expected from the wasting, was severely reduced, while the ulnar CMAP was only partially reduced. So again, this particular, and then of course the EMG didn't show any signs of paraspinal denervation. So of course, this cannot be motor neuron disease because there's sensory involvement, cannot be multifocal motor neuropathy because there's sensory involvement, and the lack of the involvement of sensory nerve potential rules out radiculopathy. The lack of EMG denervation in the cervical paraspinal muscles also rules out cervical radiculopathy. So the diagnosis here is a lower trunk brachial plexopathy. In this particular case, this particular pattern is most commonly seen in the what we refer to as the neurogenic thoracic outlet syndrome, which is usually due to a accessory rib. So normally we don't have a rib at CA, right? We have a rib at T1 and that's it. But if you have a rib at CA, can you imagine now the brachial plexus, the T1 component and the CA component has to go up and then come down like a tent, T-E-N-T. It has to go up and come down. So when it goes up and comes down, the one that is under most pressure would be the T1 component of the upper trunk, of the lower trunk, right? The T1 nerves are the ones that have to really go up from T1, go all the way up to CA because now there is an interfering CA rib, go up all the way and come down. So T1 gets affected more than CA. So because the T1 component of the lower trunk gets affected more than CA, you're not surprised that the medial cutaneous nerve, the forearm, is worse, is more affected than digit 5 sensory potential. And the CMAP of median, which is predominantly T1, is affected more than the ulnar CMAP, which is predominantly CA. So this particular pattern will make us evaluate her. So we send her straight for an MRI of the brachial plexus, and indeed there was a cervical root, but cervical rib, but it wasn't mostly bony. That's why the X-rays couldn't show it. Most of it was a soft tissue fibrous. So basically, the fibrous tissue is supposed to have one as we grow, as we develop, it's supposed to have disappeared, but in some patients it remains. But it may not remain as a calcified bone, it remains as a fibrous band, but it was enough to cause problems against the lower trunk of the brachial. Okay, so in summary, I have hopefully using a method of drawing the brachial plexus and just remembering that there are 5 roots responsible for the brachial plexus. we managed to draw out the anatomy. And you must admit that it doesn't require too much of memory. And it can be done with just a little bit of logic. Then after that, detailed anatomy, understanding the detailed anatomy allows us to interrogate various parts of the brachial plexus. And to do that, of course, for the busy clinician, the busy electrodiagnostician can use a table like this, okay, rather than actually draw out the anatomy every time. And that this table will tell you which part of the brachial plexus are you suspicious of, and what are the differential diagnoses. And therefore, what sensory nerves must I do? What motor nerves must I do? What EMG must I do? And then you can get the answer within a few minutes. Okay. Okay. So this is about 30 minutes, 35 minutes, about just nice for. So I'm going to pause now for questions. Now, the last part, which is basically prognostication, it's a little bit long. So I was hoping that we could do that at another session. So now I'm going to just pause so that we have time for questions. I think, Dr. Nijab, you may have to unmute people if they want to ask questions, I guess.
Is there a problem? Oh. Please, everyone, close the camera.
Okay.
Good.
So if there are no questions, maybe I'll just take the liberty of explaining something that I think it's important, but maybe it didn't come through very clearly just now. So I wanted to tell you this, the value of having something at the table like that, and especially for the EMG. And of course, the clinician can also use the same information. So let me go back to this again, right? Remember I said that these three nerves, we talked about the axillary nerve, the musculocutaneous nerve, and the median nerve going to the pronator teres. Right? And we realized that knowing the anatomy of these nerves allows you to ask a very detailed, a very fine-tuned, almost like an MRI. You are looking into the patient's brachial plexus and saying, can I differentiate a posterior cord lesion from a lateral cord lesion? We are talking about real anatomy. We're only talking about a few millimeters. But the electrodiagnostician is able to do it because he appreciates that these two nerves have very similar origins, very similar root, but they diverge as far as the cords are involved. So if you study this muscle and this muscle, muscles coming from this nerve and muscles coming from this nerve, if the muscles of these nerves are affected but not these, then what is the diagnosis? Lateral cord. If the muscles of axillary nerve are all denervated, but musculocutaneous nerves are all normal, then the diagnosis is posterior cord. So likewise, the clinician can examine the axillary nerve very carefully and the musculocutaneous nerve very carefully, biceps and sensation over, to try to differentiate whether the patient's posterior cord is affected or lateral cord is affected. Likewise, the pronator teres muscle, which ends up in the pronator teres, but it's a median innervated muscle. It starts from C6, C7, and unlike the axillary nerve, it goes up to the lateral cord, not posterior cord. So again, if the deltoid is denervated, but the pronator teres is not denervated, then this must be posterior cord. If the pronator teres is denervated, but the deltoid is not denervated, then this must be lateral cord. So you notice that the electrodiagnostician is actually very powerful, but the power comes not from very sophisticated information. All you need to do is just have a table like that on the board next to your EMG machine, and you can actually interrogate the EMG brachial plexus very, very carefully. Of course, for pen brachial plexopathy, it's not very useful. But today I discuss on purpose partial brachial plexopathy, upper trunk, lower trunk, neurogenic thoracic outlet syndrome. Then, of course, sometimes during accidents or bullet injuries, they may have one part affected and not another part. So sometimes you can actually help the rehab physician and the doctors who are involved in reanimating the brachial plexus. They want to know which nerves are intact, which nerves are severely affected. And that is some of the things that I'll be discussing in the second part, which is basically on the prognosis, how to understand the prognosis of brachial plexus by looking at CMAP, sensory nerve studies, as well as denervation. Okay, so I think I've talked enough. So let's pause for questions.
Okay. Anyone can give you a question?
Yes, of course.
Okay.
So I think you just need to unmute them. In the meantime, you can download the notes from this QR code for those who join later.
This is the barcode. You can scan it to give to take the presentation of Professor Umapathi. I think our friends, Dr. Abdel Nasser from Iraq, give you a lot of greetings. Okay.
They're too kind.
I think there is a question from Comer. How to differentiate C5 and C6 radiculopathy and C5 and C6 root lesion, both well preganglionic?
Okay, so can you repeat the question again, sir? So I meant to make sure that I understood it very well. How do we differentiate C5?
You have chat below. You can see it.
Oh, I do.
Differentiate C5 and C6 radiculopathy and C5 and 6 root lesion. They ask that. All is a preganglionic. This
okay.
Of him.
So I think most electrodiagnosticians and there may be other senior electrodiagnosticians listening in. So it would be good to hear their inputs. I think most electrodiagnosticians believe that when we are dealing with a nerve root lesion, okay, because the nerve root lesion must involve that part of the nerve before the dorsal root ganglion. So therefore, the sensory nerve action potential must be spared. So in an area where the patient is complaining of numbness, you put the electrode and you find that the sensory nerve action potential is normal and comparable with the other side. That tells us that the patient is numb in that dermatome, but the sensory potentials are normal. This straight away, that's why I say this, that's why I always put sensory nerves first, because sensory nerves are actually very useful in starting off the study, because straight away it tells you what's happening. So you could straight away tell you if the sensory nerves are normal in an area, like the lady with that thoracic outlet syndrome, she was numb in digit 5, numb in the medial aspect of the forearm, but her sensory potentials were reduced. This straight away makes it outside the nerve root, outside the spine. Okay, now I know there are many orthopedic surgeons, neurosurgeons who believe that nerve root compression can affect the dorsal root ganglion and structures outside the dorsal root ganglion, and the sensory potentials can be reduced. Now, I think this is not widely accepted by neurophysiologists. Now, to address this question, there was a paper, which I cannot quote offhand, but I can find it because it's in my computer, came out last year, where they looked at the lumbar spine systematically, okay? Can't remember the methodology, but systematically tried to figure out, can patients have nerve root compression post-ganglionic? Okay, that means they have spondylotic disease, but it's post-ganglionic. And they found that actually the proportion is so small that it's not clinically significant. So it kind of reiterates what we believe all this time, that if you find that in the numb area, the sensory potentials are normal, this must be a nerve root lesion. If the sensory potentials are abnormal, it is post-ganglionic, and therefore it is either brachial plexus or nerve. Okay, so for C5, C6, obviously you would go for C5, C6. Obviously you would go for. Remember we were saying just now this nerve. Okay,
right.
So C5 we don't have a sensory nerve. C6 we have a very good sensory nerve, digit 1. C6 and then C8 we have a very good sensory nerve, digit 5. For C6 we also have medial cutaneous nerve of the forearm. Okay, and for T1 we also have medial cutaneous nerve of the forearm. Sorry, for C6 I said wrongly. For C6 we have lateral cutaneous nerve of the forearm and we have digit 1 median. Okay, so if you're suspecting C6 radiculopathy, okay, C5 you cannot study because we don't have a sensory nerve study for C5. If you're suspecting C6 radiculopathy, the patient should be numb in C6 dermatome, but your sensory potentials of digit 1 median and lateral cutaneous nerve of the forearm should be normal and comparable to the other side. Likewise, a C8 radiculopathy, the patient's sensory potentials at digit 5 should be normal and comparable to the other side. Likewise, a person with a T1 radiculopathy, the medial cutaneous nerve of the forearm should be normal and comparable to the other side, even though they are complaining of numbness in their distribution. I hope I have answered that question. I'm not sure whether that's exactly what they meant, but I think it's often the question that's asked of me, can you get abnormal sensory potentials in radiculopathy? The short answer is no.
Okay. I have a question for you, Professor Oma. I have some struggling when do needle EMG and conduction study for kids just below 3 years. So, you know, also we can rely upon the sensor, the snap, because there is certain loss, incomplete demyelination. So already the shape of the snap and the values differ a lot. So how can differentiate between the pre and post ganglionic affection of the brachial plexus in kids below?
Okay, I think 3 comments. Firstly, I don't normally do kids because in our setup there is a pediatric hospital, so they do their own studies. So I cannot pretend to know about children. Okay. Number 2, you notice that I think those of you, I had the opportunity to work with some of you. You know that whenever I do nerve conduction studies in EMG, I'm often quite minimalistic because we spend a lot of time with the history and examination. And often we just need to do 1 or 2 nerves and we can get the answer. In fact, I used to be challenged in one of my training areas, training institute. Okay, tell me 1 nerve that you need to do to answer the patient's problem. Just 1 nerve. Or just 1 EMG that you need to do to give me the answer. And that's a good exercise because you force yourself to think about the most crucial nerve, the most crucial sensory nerve, the most crucial motor nerve, and 1 EMG. Now, this is particularly important for children because they're going to withdraw consent after the first study.
Yeah.
So the first study that you're going to do must be the most crucial nerve. So study that you should do. So that's the second point that I'll make. The third point about small sensory potentials, if they are very, very small, then I think the only way to solve it is to compare with the other side. Because even in our the pediatric hospitals, they don't have norms for children. In our adult hospital, we have norms for children based on various age groups and height of the patient. But in children, often I think it's better to just compare the right and the left side. And if there's a more than 50% difference, it's considered significant. I think beyond that, I cannot pretend to be an expert in children. So I may have to ask you for some of the ways that you solve this problem. Dr. Nijan.
Okay. A lot of orthopedic surgeon request a traumatic brachial plexus insult and has a query about what about the root avulsion. Please detect if there is any root avulsion or not. What about the clinical issue and importance for this evaluation electrodiagnostically?
Okay, so I think that's a very good question. I think we'll talk about that the next time when we discuss about prognosis. But that's the reason why I've at this table. And this table is actually, this slide is very important for that because normally when the patients are sent to us, even by the surgeons, usually the surgeons are the ones who are going to reanimate the brachial plexus. So they want to know which part of the brachial plexus the injury is pre-ganglionic, which is also referred to as nerve root avulsion. So if it is pre-ganglionic, that means proximal to the dorsal root ganglion. It means that the pathology is between the central nervous system and the peripheral nervous system. And we know that the central nervous system, there's no regeneration. That's why all our stroke patients do badly. But peripheral nervous system, there's regeneration. But there cannot be regeneration between peripheral and central nervous system. So root avulsion means poor prognosis. So once they know the patient has root avulsion, they are more keen to go on to more aggressive procedures to try to bypass this pathology that the patient is having, by getting the muscles innervated through other like the intercostal musculocutaneous nerve transplant, for example. Okay, so how do we? So we often tell the brachial plexus surgeons, clinically, I look very hard for for Horner syndrome. So we do something like this. We put the patient in a dark room. Okay, we use a minimum amount of light, and we see whether there is a failure to dilate with some slight ptosis. Okay, so that straight away tells you at the T1 segment, at the T1 segment, it must be preganglionic. Okay, then after that, we will do all these nerves actually. We will do medial cutaneous nerve of the forearm, digit 1, digit 3, digit 5, and lateral cutaneous nerve of the forearm. Why? Because if medial cutaneous nerve of the forearm will tell us, confirm further whether T1 is pre or ganglionic, because paradoxically the patient will be completely numb, but the sensory potential will be very good. We will do digit 5 to look for C8 nerve root avulsion. And then at C6, C7, we will do digit 3. And then for C6, we will do digit 1, thumb, okay, and lateral cutaneous nerve of the forearm. So we do all these sensory nerves, okay, and the only one that we cannot tell the surgeon, okay, is whether the C5 nerve root is avulsed. So sometimes we try by EMGing very proximal muscles like the rhomboid, the paraspinals, but we cannot be sure. So we try, but we cannot be sure. But for C6, C7, C8, T1, we can tell them confidently, is it pre or post ganglionic? So in our report, not only do we have to give a three-dimensional report, not just in terms of whether it is the proximal part or the distal part of the brachial plexus affected. That means, is it the trunk, is it the cord, or is it the nerve that's affected? We will need to tell them whether the nerve roots are avulsed, because that will have poor prognosis. But not only that, we also need to tell them from the top to the bottom. Is it the upper part, the middle part, or the lower part? So it's a two-dimensional topographical electro diagnosis that's given to the surgeon when they are very keen for surgical intervention. Okay, so not only from the point of view of whether it's nerve root, trunk, cord, or nerve, but also from the upper, middle, lower. And then of course, even nerves that are denervated outside the nerve root, sometimes a complete transection, the prognosis is still guarded. Okay, but at least there's a chance. Yeah. But for nerve root avulsion, we straight away tell them no chance.
Anyone have any question, please? Anyone? Okay, what about the timing for optimal timing for schedule as a follow-up schedule?
Okay, so I think I can leave it to you, sir. So I'm okay with as long as you give me advance notice so that I can reschedule. But usually nights are better. So around about this time, I think it's quite reasonable for me, because I would have finished work and would have come home. And but at work, it's going to be a bit difficult because, yeah. But anyway, we have a 6-hour difference with Egypt, right? So that means, yeah. I think we can negotiate, or we can do weekends, like Saturdays or Sundays or Fridays. So I think if the second and third part of this talk, I would be trying to cover some basics about what makes up a CMAP, what makes up a SNAP, then what makes how do you decide whether it's primarily an axonal disease or primary demyelinating disease, and how there's quite a bit of overlap between the two. Okay, and then finally, to summarize all of that, we will talk about how we use this information to prognosticate nerve injury, not just for brachial plexus, for any nerve injury, right? So if you have a cut sciatic nerve or a cut median nerve, how can you prognosticate whether the patient's going to recover? Do you operate? Do you not operate? So this kind of thing. So that will be there. So I'm thinking about another 2 lectures, but we shouldn't make it too long because attention span of our audience will go down. Just listening to my irritating voice continuously. But it's nice to see all of you. Please keep safe.
Okay. Any question, please? Okay. Hoping to see you in another talk.
Yes. Soon.
My greetings, my thanks for for you. I think there is a question. No, there is.
There is a question. Good.
Okay. Thank you, Professor Umapathi.
Okay. Thank you very much.
I am out.
Okay. And then, I said I must tell you that I must also welcome you to my home. This is the first time that so many people have come to my home, right?
Yeah. Well,
This is my simple house, simple flat that I live in.
74.
Okay. So, okay.
Very interesting.
Okay. Thank you.
Thank you. Thank you.
Bye.
Bye.
Thank you. Well.
Bye. To be safe. Bye. Okay. نراكم على خير إن شاء الله. See you soon in another topic. Wait, I think we have agreement from Professor Eric Stolberg. He will speak about some issues about the single fiber EMG. Professor Professor Kimura has a problem with the technology. So he cannot use the Zoom or something like that. They still till now he has no any cellular phone, Professor Kimura. So I will prepare another one to help us in some event nearly. So see you again soon with Professor Eric Stolberg. Bye. السلام عليكم ورحمة الله وبركاته. نراكم على خير إن شاء الله. كل سنة وحضراتكم طيبين. السلام عليكم. أنا هسجل المحاضرة ديت وهرفعها على الموقع عشان اللي عايز يحتفظ بيها إن شاء الله. السلام عليكم.
والسلام ورحمة الله وبركاته.